what are the objectives of this next 30 minutes? One, we want to be familiar with the treatment options that we have for major depressive disorder today. We want to know what is coming up in the horizon, like evolving treatments that we're looking at now to kind of be more mainstream as well. And then the other thing is that each one of us who is attending today is going to be a little bit of an advocate in our community to actually seek help when we need help, right? So oftentimes in our community, there is a big stigma about mental health disorders. And then we shy away from actually proceeding of advising somebody like, hey, there are options out there for you to seek treatment. So من رأى منكرا فليغيره بيده فإن لم يستطع فبلسانه فإن لم يستطع فبقلبه, right? So the middle one here is what we're talking about. Munkar doesn't always mean sin or something wrong. Sometimes it could be a disorder of some sort, right? Like an anomaly, something out of the usual that is going on. We might need to advise that person that, hey, there is something that you could do. All right, so depression is very common. That has already been talked about multiple times today. There is a stigma, and we know that this is a little bit more exacerbated in our community, and it's difficult to treat, okay? That is the part that I want people to kind of be aware of sometimes our deficiencies in treating depression and where this is going to be over time in the future. I'm not going to bore you with numbers, but we already have learned that before. The part that might need a little bit more attention is how disabling depression is. So, we always talk about like coronary artery disease and people dying of heart attacks, and that's the most common exit for most people, when they're leaving life, right? But we don't really talk about what is more disabling than coronary artery disease. Because who gets heart attacks? Like, is it young people? Is it old people? Is it somewhere in the middle? It's usually old people, right? So, they don't have that much productivity in life. They don't affect society as much as when we're talking about depression that happens in a younger age. It happens in all lifespans, but it's common to have teenagers who would suffer from depression or young adults who would suffer from depression. How many times we will have, people who would leave a year from college, because they are not able to continue their education because of their depression, or people who would take a medical leave or stop their training, or a mother who is depressed postpartum and who would need help from other family members. So the husband cannot work anymore, or the mother cannot do other things that she needs to do to help with her daughter who is postpartum depression and stuff. So for this reason, it's the most disabling disorder according to the World Health Organization. All right, and then our treatment, we're going to talk about the deficiencies a little bit in here. Okay, and another important aspect here is that this is not only a problem of today, this is a problem of the future as well. So there are some advances, say, again, I'm going to borrow the cardiology example here from our colleagues who treat coronary artery disease. There are advancements in treatments. We know that we can actually increase awareness, decrease the chances, prolong life by, having, better blood thinners, better interventions, putting stents in hearts and stuff of this sort. But the problem in mental health is actually the opposite, that we're actually facing more problems with mental health disorder. And this graph will show you the prevalence of depressive or anxious episodes among teenagers. And then the one on the flat axis in here is the year. So as we're proceeding with years, we have higher prevalence of those mental health disorders, okay? And particularly, there is a spike between that 2011 to 2012 that you can see in here. I don't know if I have a pointer or something. If you can see the pointer here, there is a spike. It's almost doubling within a span of 2 to 3 years. And then people start having theories of why this is happening. Do we have better testing, better surveillance? Are we trying to kind of find out more about depression and anxiety in children? Yeah, but that's not something new. We've been doing that since the early 2000s. People think about like, oh yeah, I think it's Facebook who did that. Let's blame Mark Zuckerberg for it, right? And Facebook is a little bit also earlier than that. I think it's 2003, 2004 or something around that, right? Around that time. People would start, blaming, a lot of the newer Instagrams and TikToks and stuff of this. So those are a little bit later. So what happened around that time? We changed from exposure to electronics and social media from only at home in front of a computer to every time on our phone. That is the advancement of 4G. Okay, so 4G became widespread in the United States of America around that time. So that brought this bullying that was happening at school, or comparison and comparative competition that was happening at school, to all the times. We don't have a safe space anymore. Previously, when in my generation, there is another kid who has like, the most recent Adidas or something like that, and you're jealous of them or whatever. Then you go home, you're chilling, right? You're just like your brother, both of you are wearing the knockoff shoes, right? But now you go home and you're opening those devices, and then you are still seeing those comparisons. Maybe not with the exact same friend, but with other things related to society. And I see that in my own children. You have to limit the time, otherwise you're actually, continuing that stress 24/7, right? Okay, all right. And do we see that more in boys or do we see that more in girls? More in girls. Okay, so they're more fragile to that, they're more exposed to that, and this graph will show you how it's almost doubling. I'm not saying that boys are not exposed to it, but not at the same percentage as we have. So that's to just kind of enlighten you to the importance of finding a solution, because again, this is a problem that's going to progress over time, it's going to be worse. All right, so previous speakers already had talked about different things that makes us depressed. Okay, so the etiology of the illness is important because that's going to tell us how we're going to treat it. Okay, all right. So let's say an example in here. Let's say somebody was, getting engaged. She's very happy, inviting people for her wedding. Things are sorted out the way that she was hoping for, and what have you. And then for some reason, there is a breakup in this engagement. فكسة الخطبة, right? In Arabic, right? Okay. So this person now is like shut down to herself. She doesn't want to go out anymore. She's barely eating. She is not able to focus, behind on school or work. She is not sleeping very well, right? All the clinical depressive symptoms that Dr. Adel talked about already, right? Okay. So, and then she comes to the psychiatrist, and then her mom jumps in, oh, she just broke up with her fiance. Why would she have the depression? So many people break up and stuff of the sort. Is it this reason? If we get her married to somebody else, we're going to solve the problem? We wish, no. All right, so then the etiology here would be a little bit superficial if we thought that this most recent trauma is the only reason for that clinical depression to happen. It is multifactorial. There is the genetic predisposal. Some families have more mental health disorders than other families. Dr. Isra already mentioned the genetics, right? There is the way that this person was raised during their early childhood. Dr. Isra also talked about the attachment. That's a mother-child, or the environment that the patient is growing in. And in that axis also there is the environmental factor throughout her life, right? How stressful school was, how stressful was it during college, what was going on with her previous experience and relationships and stuff of the sort. All of these prepare for that last traumatic event to lead to that depressive episode. Make sense? All right. Now, okay, well, and the nutritional components of things that we're talking about are in the environment thing as well, right? Inflammatory processes that could happen, sometimes, exposure to certain viruses and stuff of this sort are in the environmental thing. Okay, all right, and then somebody would say, okay, well then, wait a second. So this is similar to medical illnesses, right? I'm going to borrow the cardiology example again. Somebody who's working up on a roof on a hot day and they're dehydrated, their heart is beating too fast, they're having chest pain, they're telling their family members, they call the ambulance, they go to the hospital, they tell them that you have a heart attack and we're going to put a stent in your heart. Okay, and then this person is asking the cardiologist, oh, just because I was working on the roof. And the cardiologist would be, it's not the only thing, okay? So this is what triggered, this is the straw that broke the camel back. Now I'm using Middle Eastern kind of example. All right, so this is the last thing that led to it. But you have genetic predisposal. Did you have family members who had heart attack in young age? Oh yeah, my uncle did that, my grandfather did that, right? Okay, how are you living your life throughout the years? Are you eating healthy? Are you exercising? You are a smoker, you are doing all of those things. Those are the environmental factors, right? And then that immediate stress that put too much work on the heart for that day, caused the ischemia of the heart and the person has a heart attack. All right. Why is this important to understand? Because the cardiologist is going to put the stent to solve the problem now to kind of cause perfusion back to the heart, meaning that we provide the blood supply where it needs to be. But also when he's discharging this patient from the hospital, he's going to prescribe 5 medications. I swear to God, there are 5, okay? There are 2 blood thinners, 2 blood pressure medicines, and 1 medication to decrease cholesterol, okay? Every single patient who gets a stent are going to be walking out of the hospital with those 5 medications, okay? All right. And then he's going to tell him, you don't smoke, you decrease salt in your food, you're going to exercise 3 times a week, lifestyle modifications, right? Okay. What did the cardiologist do? He solved the immediate problem. Then he was trying to work on the environmental things that were accumulating over time by those medications, the genetic component of things by those medications. And then he did the lifestyle modification, which is the environmental thing that led to where we are. Why am I telling you about all of this? Because when we need to treat depression, we do the same thing, okay? All right, so we need to decrease the stress that the patient is suffering from. So sometimes we help the patient go into a medical leave from work, for a little bit of time to decrease that stress. Or, the person who broke up, فكسة الخطبة, her mom and her family are going to surround her with love and care, and it's totally fine. He's a jerk, okay? All right. And then, the other part is going to be therapy. Okay, so cognitive behavioral therapy is going to be, that's not the only example, but therapy is going to be important in here. That is correcting those environmental things. This is our way of thinking that we need to adjust over time. All right, I'm going to summarize, a cognitive behavioral therapy quickly. Hopefully it registers a little bit. The idea here is that our thought patterns take a certain way when we are depressed, okay? So, let's say an example of somebody who's applying for a job, right? So they're applying for jobs, they're sending their resumes, they're getting a lot of denial letters and a lot of rejections. They could look at that and say, oh, I'm a failure, I'm not really worthy, to be hired, I'm useless, all of my education went to waste and stuff of this sort. The feeling that comes from this thought is going to be feeling of despair, hopelessness, worthlessness, etc. Their behavior is going to be, they don't want to put themselves out, right? They don't want to be in a networking event, they don't want to introduce themselves because they feel ashamed of themselves, right? So the behavior followed the feeling followed the thought. So if we can correct this thought, if we can take that, okay, you applied, you got a denial letter, that might not have been the best fitting job for you, right? We might correct that by okay, we got a denial letter, let's see what's in our resume, what's in our previous experience that does not really fit the job market today, and learn those skills, right? Inna ma'al usri yusra, inna ma'al usri yusra. Two yusras, right? Two eases for each struggle, right? Okay, so we could look at that from the positive, perspective. If we did that, then our feelings are going to be a little bit more balanced, okay? We're going to understand that, hey, there is difficulty, but with that comes strength. I'm going to feel empowered. I'm going to feel like I am in charge. I am in control. My behavior is going to be, I'm going to apply more. I'm going to take courses. I'm going to look at what's going on in the labor market nowadays. How can I network with people, etc., etc. When that changes, my thought about myself as not being, well-trained for is going to change, and it's going to be positive, and I'm going to be in a positive cycle from that point on. That is the key in how we change our thinking. Not everybody is capable of doing that, okay? So obviously we need a coach, we need a therapist, we need Dr. Isra to kind of work with this person on regular basis, on every week, on what have you, and stuff of the sort. While we're doing that, we might need medications to make that a little bit easier for our brain to have what we call the neuroplasticity, to kind of change the circuits of our brain so we would have that as default network, okay, other than having, instead of having the negative networks in there. So we use medications like SSRIs, selective serotonin reuptake inhibitors, like, Prozac and Zoloft and Paxil and Celexa and all those kind of ones. And then we have another class of medications, which is serotonin norepinephrine reuptake inhibitors. Those are like Effexor, Prestige, Cymbalta. And then we have some medications that are more activating, like Wellbutrin, bupropion. It increases norepinephrine and dopamine in the brain. There are atypical antidepressants like mirtazapines. If those don't work, then we add augmentation treatment to medications antidepressants as a second step in treatment. That's when we add a mood stabilizer. And then if that doesn't work out, then there are other things that we'll talk about. What is, from what you learned, this is a test for what Sister Iman was talking about earlier. What is the most common side effect of SSRIs? What do you expect is going to be the most common side effect of antidepressant medications from the SSRIs class? Say it again. Weight gain, okay, all right. So, it's generally GI side effects, right? So when we're talking about nutrition, somebody mentioned serotonin exists in our stomach a lot, right? So very often, we start a patient on a serotonergic medication. The first couple of weeks, they're groggy in their stomach. They might go to the restroom more than usual, or they might have constipation, either one of the two. So, but that speaks, to the importance of nutrition and how our gut and our brain are very connected, okay? All right, so when we don't respond to medicine, there are more advanced treatments. That includes, ECT, TMS, and VNS, and I'm going to talk about a few of those now, okay? This kind of summarizes what we're talking about with medications. All right, remember when I told you that treatment of depression is a little bit difficult? Okay, so the first medication antidepressant that we try, that is when we have the best of the luck, okay? So about 1 out of 3 patients are going to respond to this first medicine. If we don't respond to the first one, it's about 20%, 19% or something of this sort. When we don't respond to the second one, we go to the third one, it's about 6%, okay? When we don't respond, we go to the fourth one, it's about 5%. And then people will look at us like, oh, you guys are a total failure. Only 5% and you're still practicing? What are you doing here, right? And in our defense for psychiatry, we deal with the human body. And our human body is similar to any other specialty. When we don't get things done from the beginning or as early as possible, it becomes a little bit more resistant, okay? So there's no difference between the doctor trying a couple of antibiotics and now the bug is resistant and treatment of depression. Once we go through certain stages, we're going to build a little bit more resistance. That makes the cure now or the treatment that we need to get somebody into response or remission is going to be a little bit more difficult, okay? And that's not only specific for psychiatry. I promise you, the cardiologist does have patients who are resistant hypertensive. And our colleagues who treat cancer, you can ask them what happens after 2 failed chemotherapy courses, right? They probably will tell the patient that, that's it, right? So the fact that we do have treatments beyond just medications is actually promising. And that puts, mental health, despite our stigma about it, that puts it ahead of a lot of other specialties that we spend trillions of dollars in the US on, okay? I particularly mentioned cardiovascular and I particularly mentioned cancer, just to kind of give you the comparison of how mental health is more disabling, but it gets none of the money, okay? It gets none of our attention, it gets none of our appointments. And everybody doesn't think this is important. While we think, the cardiologist and the cancer doctor and the Moffitt Center and all of those things are important, right? And our utopia in Tampa is missing like a center for mental health similar to Moffitt. All right. Also, the faster that we get somebody into remission, the better the general outcome is going to be. Okay, so 6 times more likely to maintain that remission if we get the patient better in the first couple of weeks of a major depressive episode. All right. So, do we have treatment options beyond the medications that we're talking about that are faster in acting? Okay, that they can actually get somebody into a response faster? Yes. There is something called ketamine. Okay. So ketamine is a street drug in the past. It's referred to as Kit Kat, Special K, Vitamin K, not the kind of vitamin K that our nutritionist was talking about, all right? Okay, and when I was preparing this thing, my son was running around like, I want some of that. I was like, who doesn't? That would be even better than the comedy show last night. So it's a drug that makes you dissociated. It makes you a little bit elated, when somebody consumes such a drug. And it was approved for the reason of anesthesia since the 1970s. And here recently, in the last few years, it had been used as an antidepressant for treatment-resistant depression. And it was not really FDA approved, so it was done as off-label. So, and you require an infusion. The anesthesiologists who require to get an IV line for the patient and do an infusion over about maybe 40 minutes or so, and you repeat it multiple times. So it was not really ready yet for like daily use, all right? So there was a pharmaceutical company who took half the molecule of ketamine, so whenever you were making a molecule in the lab, you have an R and S, two enantiomer, what we call it, so those are 2 mirror versions of the molecule. So they took esketamine and they isolated that in a nasal spray. So with that, you can actually, bring the patient into the office. This is a very controlled environment. You cannot really do that at home. You come to the psychiatrist's office, we watch you do the inhalation in each nostril, and then we keep you in the office for 2 hours. And we repeat that treatment twice a week for a month, and then after that, once a week for the second month. And some patients would require maintenance every week or every other week, okay? So that is very fast acting. Suicidal thoughts, basically within the first treatment session, you would know whether you're responding for suicidal thoughts or not, and this is the shape of the nasal spray. Think about it similar to the Flonase kind of thing, but you do it under supervision from a doctor. All right? Are there no side effects of this treatment? Yes, there are. Anything that would make you high could make you addicted. But the chances of addiction when you're doing a treatment under supervision is significantly lower than if you're taking a medication at home and stuff of the sort. And too much anti-NMDA medications, this is how the medication works, which is not something that you might need to worry too much about. But giving too much glutamatergic things to a patient could actually lead to a psychosis. Has anybody seen the movie Brain on Fire? It's okay. It's not totally haram to watch movies. Okay. All right. Brain on Fire. Anyone? Okay. So there is a book that was written by a journalist. I think she was a reporter for the New York Times. I think Miss Callahan. And then she had this psychotic manic episode that everybody was trying to diagnose and they were not able to. And then finally she met this smart Syrian doctor. Of course he's smart because he's Syrian, right? So that's Dr. Najjar. He is, unfortunately, a neurologist, not a psychiatrist. And he diagnosed her with anti-NMDA syndrome, okay? And with this, basically, you have too much glutamate in the brain, and that would lead to the psychotic episode, okay? All right, so the lesson learned from that is that don't do too much Special K, all right? Okay, so what else can we do to have the same newer way of treating depression, but without really going for that particular dissociative drug? Well, nowadays there is a medicine that you can take orally, meaning it's just a pill, just like any other antidepressant medication, that combined Wellbutrin or bupropion, which is an antidepressant that we know for quite some time, with cough medicine. That's where Robitussin is, right? That cough medicine is dextromethorphan. When we give those two medications at the same time, we actually hit those NMDA receptors, similar to what we do in ketamine, without really causing the surge, so we don't have the dissociation. All right, why am I telling you this fact? Because I'm telling you there is something beyond the classical medicines that we're doing now that are coming to the market to help actually with depression treatment, okay? So there is hope that we're going to improve our antidepressants over time. And this particular medicine has significantly better outcome than the classical SSRIs that we had before, okay? All right. So what else can we do? Let's say that we have been on medications. Medications are not helpful. Are there any other treatments that are faster acting and very effective? ECT is the gold standard for so many years, particularly in our back home countries, right? Like back home in Syria, they still do ECT as, the treatment of choice for treatment-resistant depression. This is a little bit aggressive. You come to a hospital, you're under generalized sedation. The psychiatrist is delivering electricity either bilaterally or unilaterally, one side or two-sided to the brain, and then we're inducing a seizure in the brain. That's like a reset. Like, if Brother Nejimos's computer wasn't working despite plugging it in and what have you, you unplug it and plug it back again, right? So similar idea, but for our brain, okay? So when we induce a seizure, we're basically trying to reset the brain back, to where we need it to be. The problem with that, it's a little bit invasive treatment, and some patients could have cognitive problems with it. They could have some memory issues when they do ECT. So, did we improve on that treatment to make it a little bit more appealing to people and to have less side effects? Yes. We can actually use magnets instead of using electricity. So as we have learned from Faraday's law, every electrical field can actually induce a magnetic field, right? So a similar idea in here. We can actually use magnets to induce activation of our brain without really delivering electricity to the brain. So that's what transcranial magnetic stimulation stands for. And then the area of the brain that we want to stimulate is basically the dorsolateral prefrontal cortex, okay? Remember when I forgot who the speaker was talking about that, how our limbic system is where we have the feelings and what have you. It disconnects from our frontal lobe when we are in a depressed state, when we're having that, unilateral emotion that is difficult to kind of get out of. So what we want to do is that we want to stimulate our brain cortex, particularly in the frontal lobe, to kind of take control over our limbic system again, and that's why the target area is in the frontal lobe. You don't really need the details of the different protocol of TMS, but in summary, this is a treatment where the patient will come to the office every day, Monday to Friday, 5 days a week for 6 weeks. You will be sitting on a reclining chair. We put a magnetic coil on the side of the head. That magnetic coil will deliver those magnetic pulses to the brain. And then it's similar to when you go to the gym to induce muscle growth. You're trying to induce brain activation in your brain. So that's why the consistency. You don't need to be under any sedation. Patients are completely awake during the treatment. They drive themselves in and they drive themselves out. And there is no systemic side effects. This is not something that will cause stomach issues or anything of the sort. All right. This graph tells you that the first thing that we do for treatment of depression, remember, we do psychotherapy and an antidepressant for somebody with severe depressive episode. If it's moderate depressive episode, just psychotherapy should be fine, okay? But the first thing you do, psychotherapy plus medication, you will increase the odds of response. If you're not responding, then we switch the antidepressant. If you're not responding, we add augmentation. If you're not responding, you can do TMS. That will get you back to as if you're at the first trial of treatments. So that's the first one in here. When you do TMS, you are about as fresh as it could be, okay, for chances of response. Okay. Well, you told me every day, Monday to Friday, 5 days a week for 6 weeks. Do I work for you? I'm not going to come to your office every single day. This is too much. Can we do it faster, right? So that's where a new modality or a new protocol of TMS treatment came to the market or came to clinical research initially. And then finally now it's FDA cleared. We don't really have it that widespread yet, which is doing 10 treatment sessions a day for 5 days. So, somebody could say, I can take a 1 week vacation. I cannot come to your office every day. Can we do the treatment in an accelerated form? Yes, it could be done. You do it 10 treatment sessions a day separated by 50 minutes. So you basically spending the whole day in the clinic. Good luck spending a whole day with me. And then doing that over just 5 days, and problem would be solved in about 80 to 90% of patients. Significantly good response rate. Now, Whenever you hear in medicine 80 to 90%, you have to be suspicious, okay? That's sus, as my daughter would say. That's sus, okay? So because it's sus, we have to look like, is this really true? The answer is it's true, but you have to evaluate that patient in 6 weeks after the treatment, and now you tell me the number. Because remember when we're doing classical TMS, we're taking 6 weeks of treatment, right? So we need to compare an apple to an apple, right? So that's my talk. I appreciate you guys listening to this, and we'll take questions later.